Welcome back to the Physician's Guide to Doctoring. On this week's episode, we have a guest host, so please be the same respectful audience you are for me and enjoy.
Hey there, it's Brad. As someone who's passionate about podcasting, I've always thought there should be more support for physicians who want to share their stories and expertise. That's why we're launching Doctor Podcast Network.
We're bringing together a community of physician podcasters with one goal in mind: to provide the tools, connections, and resources you need to grow your show. So whether you've been podcasting for a while or maybe you're just starting, we've designed this network to support you every step of the way, and we're going to help each other rise, not compete.
If this sounds like something you benefit from, we'd love for you to join us as we get closer to launch. So you can sign up at drpodcastnetwork.co for early access. Stay tuned for more details in the coming weeks. Really looking forward to what we can create together. Doctor Podcast Network, where doctors podcast.
Doctor Podcast Network, where doctors podcast.
Doctor Podcast Network, where doctors podcast.
I'm so excited today to have our guest, Dr. Brittany Lamb. She's an ER physician with a special interest in making sure that patients who are living with dementia get the kind of care that they should get and that they want to get. And she's a real advocate. So let's get into the interview.
Hey, this is Brad Block, host of the Physician's Guide to Doctoring. This is a personal and professional development podcast for physicians where we have experts on the show that try to teach us everything we should have been learning while we were memorizing Krebs cycle.
In the ER, Dr. Lamb grew frustrated witnessing the overwhelm and stress that seems to go hand in hand with decision makers' need to speak up for someone they care about. Recognizing the unique challenges that come with medical decisions in patients living with dementia, she felt compelled to extend her expertise beyond the walls of the hospital. To bridge the gap, Dr. Lamb works online to empower medical decision makers with the knowledge and tools they need to make informed choices by offering both free and paid resources. Dr. Lamb lives and works in Northern Virginia. Her time is spent flipping between the ER at night and her work online during the day. Downtime goes to spending quality time with her friends, family, and her husband. So welcome, Dr. Brittany Lamb. I'm really excited to have you today.
Thank you for having me.
Thank you. Yeah. So let's start at the beginning. What's your origin story, as Brad always says? How did you start becoming an emergency medicine physician and then find yourself to be really an advocate for patients living with dementia and their caregivers?
Yeah, so I've been practicing in the ER as an attending since 2017. I think a lot of ER doctors fall into it by process of elimination. There were a lot of things I didn't like about all the different rotations in medical school, so I just fell into the ER. But I've had personal family experience with dementia. So my grandmother lived with us when I was growing up, when I was a teenager. She had vascular dementia, so I was exposed to it pretty young. My father passed away when I was in medical school before I graduated. He had glioblastoma. Going through that process, he didn't live with dementia, but he had this neurodegenerative disease, the tumor. So those experiences shaped things for me. And then being an attending, I got really frustrated by seeing people who were aging in the ER for foreseeable medical complications of their known illnesses and no one really knowing what was okay and what's not okay. I like shared decision making. It's how I was trained. And I feel like for people living with dementia, a lot of them can't engage in shared decision making. And you're having those conversations with their family members. And a lot of them are caught like a deer in headlights. And so I was really frustrated by it and it was really bothering me. It was probably one of the root causes of me getting very burnt out by the ER. So I decided to come online and do this work as like my, I don't know, crusade. So that's why I'm here. Yeah.
Yeah. So I think it'd be helpful. So give us like a typical example of somebody who comes into the ER who's living with dementia and maybe an exchange you have with a caregiver that would frustrate you. Just a simple exchange.
Yeah. So there's a lot of stuff that we can do in medicine to protect people's quality of life, but also prolong life. And I think sometimes just making the decision about whether or not to stay in the hospital can be really stressful for people. Say somebody is dizzy or weak, maybe they're a little orthostatic, maybe they have a urinary tract infection, maybe they have other medical problems, like maybe they're a little volume overloaded, they have CHF. And can you manage this at home? Do you feel comfortable with this? A lot of times it's just like making decisions that are would be more straightforward for a person who's not living with dementia. And a lot of times it's whether or not to hospitalize the person. I think that can get really challenging for a caregiver to navigate. So we all know that there are risks associated with being hospitalized.
Yeah. That's interesting to think that even just the very beginning of, do we even want to admit this person or do we want to send them home? And I'm sure you guys always worry about liability and all of that. And then you're thinking, am I sending this person home with a caregiver who is able to take care of this person?
Yeah, there's some of that. There's some of that in there for sure.
Yeah, just quick vocabulary lesson that I need. So you say a person living with dementia, and I'm curious why you don't say a person with dementia or, yeah. So tell me why you say that and where that term.
Yeah, if anybody's interested, there are a lot of people on social media trying to provide support for caregivers and care partners of people living with dementia. And this is what they say: living with the disease does not define the person. And I think it's like that with a lot of chronic illnesses. I think we're becoming a little bit more sensitive to the language that we use. Yeah, I think the accepted term really is to say that a person is living with dementia. Just because a person is a disease causing dementia doesn't mean they can't still make their own decisions, that they can't have wonderful quality of life. And I think sometimes when we try to label them as that disease, it can take away from the person that they are.
Yeah, I like that. The autonomy. It defines that it's still a person with this illness.
Yeah. And then there's like other terms, care partner versus caregiver. People may want to be a little bit sensitive to that. So, care partner is typically somebody who's advocating and walking the journey with the person, typically someone in the earlier stages of whatever disease is causing dementia. And so they're more of like an advocate. And a caregiver is someone who's providing care. And so that's usually more towards the middle, the late middle, and then the end stages of diseases. So that might be something people want to be aware of, that kind of language. And if I could put a plug in for a term that we should not use anymore, is that okay? Yeah, so I really love for people to stop saying that people are demented. I think that it's very dehumanizing for people. And so it's a term, I think we all know what it means when you hear it. You're like, okay, this patient lacks decision making capacity. And likely much of the story that they're going to give you, the history is not going to be reliable. And also, they may not be able to tell you how they're feeling very well. You may not be able to even ask them, does your chest hurt? Does your head hurt? And be able to rely on history. So not just the story, but how they're actually feeling, they may struggle to communicate. So I think we use it because it communicates a lot of information, like in doctor speak, very quickly, but it's not something that is okay to say anymore, especially not family members and caregivers. It's not a nice word. So
Yeah. I do remember the first time I heard somebody said this patient is demented. And remember the first time I heard that term in a lecture hall as a medical student. And I hadn't heard that term in a long time. And the last time I had heard it was like as an insult among kids. Are you demented? That kind of thing.
Mm.
It felt so politically incorrect. I couldn't believe it. And then I realized like that was the medical term. Maybe it's changed since, I don't know, maybe even then it was not okay, but it's just changed over time. And it's nice to hear like clarification on that.
yeah, I have colleagues who I've worked with they're a bit older than me, maybe 10 years more ahead of me in their career. And they've used that word in describing their own parents.
Yeah.
So I don't think that we mean anything by it when we say it. Like I said, I think it communicates a lot of information, but yeah,
Yeah.
we should try not to use that term.
Yeah. So, a question for you, because I'm a family medicine physician, and I think a lot of our physicians are not emergency room physicians. And what happens a lot is I have a patient who comes in for the first time, and it appears in just even a brief conversation that there's some notable memory loss, right? Something about the interaction makes me think I'm not sure that this person is completely following this conversation, and I'm a little worried that they're not going to follow up on what I'm recommending. In your experience, is there a way to ask them politely about memory issues, or is there a way to navigate that situation so you make sure that this person gets good care?
Yeah, so that's such a good question. I feel like we could talk about this for a long time. So in the ER, I can be more direct and I don't have to worry necessarily about a longitudinal relationship with patients. So the way I sometimes will approach it is a lot of my patients tell me that as they're aging, their brain is working differently or they're noticing things that they used to be able to do that they're now struggling with. that's something that you could just say and then assess their body language and how they take that. And maybe ask them if they have any concerns about the way that their brain has been working. Um, I think also being sensitive to memory, yes, but also word finding issues, maybe with handling their emotions or feeling like they are overreacting to things. Then also, if there's a decision maker or a care partner or caregiver there, look at them and see if they're trying to non-verbally talk to you. I think that's really important that we open space to hear from them. I think it's so hard for us because we want to respect patient autonomy and privacy. It's drilled into us, right? But being able to assess a patient's capacity and also teach their family members or the people who are advocating for them whether or not they have capacity to make medical decisions is a skill that we really need to brush up on and practice and use. And the other thing that I'll say about this too is that I think we should also be aware that there's symptoms of diseases causing dementia. There's a symptom we should know about where a person lacks the insight into knowing that they're living with a disease. And so a lot of times when you have a conversation with someone, you may point blank ask them if they're struggling and they may tell you no, and you clearly can tell that there's something going on there, right? And I think maybe asking if you can have them bring someone to the next visit if they're alone, or saying, I really want to make sure that you receive the type of medical care that you would want if at some point you're not able to make your own decisions. Can you bring somebody to the next visit so we can talk about what's important to you? Putting in a bug for advanced care planning, planting that seed. So a bug in their ear, if you will. Those are some of my thoughts, but a lot of different ways that you can go.
Yeah. That brings me to, I know you do a lot of work on physician bias. The assumption, correct me if this is not exactly what you mean, but the assumption that people who are living with dementia have the desire to have less invasive medical care because maybe we're optimizing quality of life. So do you have any recommendations how physicians can check our bias, how we can better read a situation just to offer the most appropriate treatment to these patients? So say you have somebody, for example, who comes in, maybe you're a dermatologist, you're doing a skin check and you notice something and it looks like it's going to need a really big invasive kind of procedure. How to proceed from there? If you think that it's probably slow growing, you may not need to come out right away. Your bias would say this person might outlive this disease, but your inner physician says I should offer all the options. So if you could just give us some guidance.
Yeah. Yeah. I think that, like you said, a lot of important stuff right there. I think it's being aware if you have a bias. So we always talk about that with bias. Like the number one thing is to be aware that you have it. So I have a bias towards quality of life over length of life for myself. And that's how my family is as well. So I have to sometimes check that and ask family members or patients what's important to you. What does living well mean to you? Do you have strong preferences towards prolonging your life or protecting quality of life? So being aware of it, I think that if you're realizing in your mind that you may offer different options because the person's living with dementia, I think that you communicate that in a way like you're living with dementia or to their family members. And so sometimes that can make the recovery process different. It can make complications harder to manage. And so I want to make sure I present all the options available to you, but I also want you to understand that I understand that it's more complicated because you or your person's living with dementia. And so I want to be open with you about my thoughts and my concerns because they're living with dementia. Opening the door to goals of care and conversations about what living well means to this person and what quality of life is like part of the decision making process.
So once you started, this thing makes me think. So once you started being so aware of this third conversation, whatever, this space in the room that wasn't being addressed as an ER physician, I'm curious, like you just said, now I'm going to list out some more complications around dementia. Like, how has being more aware, how do you incorporate that into your emergency medicine practice? And like, how does it make you a different kind of physician?
Yeah, I think that I talk to people more about what's important to them as before I start talking about what the care options are. I think that how we make medical decisions is based on what options are available to the person, how likely those options are going to impact their quality of life and get them what they want and get them what their goals are. But I also think that people are not as informed and educated about treatment options and about disease progression. And so I'm more open to in the ER. Like the other day, I asked outright a daughter, I said, "Look, I'm really worried about your mom. She's living with dementia. We were admitting her to the hospital. She has urinary tract infection, likely aspiration pneumonia. And she's like teeter tottering on like meeting criteria for sepsis, severe sepsis, watching her blood pressure drop a little bit. And so it's, can I talk to you about my concerns about what might happen going forward? Would you like information about some of the decisions that you might have to make in the hospital? So I think it's made it so that I focus more of my conversations on trying to figure out what this person's values are and what's important to them, and trying to make sure that the family understands that my job as the doctor is to help this person receive the type of medical care that they would choose for themselves if they were capable of learning and becoming educated and taking in that information to make their own decision.
Yeah. Sounds like a lot of reading the room. Are they even aware? Are they educated? Do they seem to get it? Or do I need to take the time to explain to them that things may not go as they think if they get admitted?
Yeah. And so as an ER doctor, I'm begging people, begging other doctors to start incorporating these types of conversations about identifying what quality of life means to a person. Do they value quality of life? Do they value length of life? Most people value both. But at a certain point, a lot of people start to value quality of life more. And it's not just that, it's what does that mean to them? Because that's how we make medical decisions, especially in stressful situations. Like people need to have already had these types of conversations. And I know that we're all time pressured. And I know that's a big barrier. And when you're taking care of someone living with dementia, you don't just have them as your patient. You have their advocates as part of the team. Because even if right now in your office or wherever they can make their own medical decisions, if they get injured or sick, they're highly likely to lose capacity temporarily and then maybe even permanently now. And then we've lost that ability to have this conversation before that happens. I don't think we need to go at people trying to ask them if they want CPR and they want to be a do not resuscitate. I think we need to go at people like, hey, you're living with a disease we know is going to impact your quality of life. So let's talk about what quality of life means to you so that we can make sure that you get the type of care that you would want when you're not able to speak for yourself anymore.
Yeah. It's remarkable you do this at the ER because I imagine when you're so busy and stressed and you have high acuity and you're dealing with this older woman who's living with dementia, who's here with the UTI, and in the next room you have somebody you're keeping your eyeball on because you're worried about them coding. It's hard to imagine trying to navigate and balance all of that. One, it's impressive. But two, I want to learn from you. How do you do this in an efficient way during a visit? It sounds like you're very blunt, which is in a good way, right? You just get to the point. You don't want to waste their time. But I'm curious if you learned any strategies to have this conversation in a brief way? Because I think most physicians operate in a little bit of a time crunch. And it'd be how we can say what you're about to say in under a certain number of minutes.
No one's ever asked me that question. That's something that I should probably try to organize and put down in writing. But I think it's like asking permission to talk about things, because if you don't get that, then it's not the right time. Reading the room is huge because there are times where it's just not appropriate. But I also think telling them what you are trying to accomplish. I'm here for you. I'm here to make sure that I do everything in my power to make sure you get the type of care that you would want, or your person gets the type of care that they would want. And so there's a lot of things that I would like to educate you on and ask you questions about. And some of it may be uncomfortable, but we discuss it now and it's uncomfortable and weird now, or you get thrown into a situation where you're super stressed out and you may not be able to make the decision. And that's another thing too, like in the ER, sometimes I just don't feel right talking to people about this because they're not in a mental space where it's appropriate. And so that's why I think planting seeds for talking about quality of life and what living well means all the time.
Right.
Every doctor can do this,
Right.
and start just planting the seeds. Then it helps take better care of people.
And I think we all feel this way. I see this in the primary care setting where I think, oh, this person has advanced metastatic cancer and I'm waiting for their oncologist to bring something up. but somebody else is waiting for their pulmonologist because it's metastatic lung cancer, for example. And then everyone's looking at me because I'm the primary care doctor. And you know this patient best. And sometimes there's a lot of who's in charge, but I think
Yeah.
I totally agree. When I do this work, I talk a lot about just everyone's job is just to plant the seed. And if there's an opportunity to say, look, I don't think this is going to go the way you think it's going to go, this is what I'm worried about. In my case, it might be, I'm worried that the next time you go to the hospital, you may get intubated, or you may not be able to leave the hospital, or you may end up going to a nursing home. And so therefore we have to make decisions about, do you even want to go down that path? But I do appreciate that you try to do this in the ER, because I'm sure that is probably one of the most challenging settings to have these conversations.
It's honestly, it's because of me as a person. It really bothers me doing things to people that if they were able to be informed. It's so upsetting to me as a human. So I don't really feel like there's another way for me to do it. I like have to say something.
Yeah.
So I try to.
It's your compassion. And that's what comes out, right? Is your compassion. We need more of that everywhere. And I'm sure it's really hard to maintain in the ER with some of the cases you guys deal with. But tell us a little bit about your work that you do educating caregivers, because your focus is on that area, right? Is how to train caregivers. You talk about it.
Yeah. Basically, what I try to do is help them anticipate and learn about the medical decisions that they are most likely going to have to make on behalf of the person. So there's medical complications we all know that happen to people who are living with dementia, typically more towards the end stages of disease, specifically because of whatever disease they have causing their dementia symptoms. But what I find more challenging is when they're in like the middle stages of the disease, or maybe the early late stages of disease, and they have other medical problems. So heart disease, kidney disease, all the things. And the decision makers are trying to navigate, what do I do? What's too much? What's too little? And so what I do online is help people assess their person's risk and start learning about these conditions and how they can progress their underlying medical problems and how they're treated from like most to least aggressive, especially with a focus on care inside of a hospital. What is critical care? What does being in the ICU, being on a ventilator, what does that look like? What is the care of sepsis? Just really common things that happen to people. I think people should have more understanding so that when they're put in these situations, they already have some underlying education and they're not as stressed out. So I do a lot of stuff online, and probably the best way if people are interested in like connecting with me and learning from me and teaching me, because I want to learn too, is to sign up to receive my email. So if you go to blammd.com/email, you can connect with me. You can ask me questions, tell me about situations with patients. What I do for caregivers online is do live question and answer sessions a couple of times a month on Zoom. I do that for them. I share those recorded replays with them. And then I have a bunch of free resources like blog articles. I put out videos. And then I have two different courses now, one that's under $100 and one that's under $700. The medical decision making 101 is like a high level what you need to know if you're advocating for someone and making their medical decisions and they're living with dementia. And then my big program, Make Your Plan with Dr. Lamb, is really I teach people how to think through the decisions that they're most likely going to have to make. And it never replaces what we do with patients one-on-one. It's just access to information. Big part of it is setting goals of care. So are we going towards prolonging life? Are we focusing on trying to protect quality of life? Or are we in a situation where we're moving more towards comfort care? Yeah.
That's great.
That's what I do.
I follow you on social media, and just the things you say, it comes out. It's so clear that you care about this and that you care about your patients and that you want them to get good care. And I think that's probably the best teacher out there, is the one who is really invested in their student, which happens to be a caregiver in this case.
That I've been told by caregivers that a lot of physicians will say, oh, they know what year it is and who the president is. So they're fine. Just remember that just because someone can answer orientation question doesn't mean that they have medical decision-making capacity. And just please don't blow off the caregivers. If they clearly have the best interest of the person in mind and they're trying to do what's best for this person, there's a lot of secondary gain issues that can happen in this space, but just have an open mind to listening to them and hearing them out if they have concerns.
That's great. All right. So people can find you online, on Instagram, on LinkedIn, and we'll show the information in the show notes with how to get in touch with you. But thank you so much, Dr. Lamb. It was great. I learned something. Even though I'm in this space, it's always nice to meet others who are really involved. So thank you.
Yeah, thanks so much for having me. I appreciate your time.
All right. Thanks.
Thanks for listening. I have a favor to ask. You listened to the episode until the end, which means you either fell asleep or you really liked the episode. So please share it or like it or comment on a social media post or write us a 5-star review. Something. It would really help me out. And maybe what you learned from this episode can help someone else too. The views expressed in this episode are those of the interviewer and interviewee and don't represent the views of their employer or even their significant other. Even though the magic of podcasting make it sound like I'm talking directly to you. This is not a doctor-patient relationship, and this is not medical advice or financial advice or really any advice. Thank us again for listening to The Physician's Guide to Doctoring.